evening, friends. Yeah. KSOS has been very active in observing the World Glaucoma Week under the leadership of our president and his team, conducting multiple academic and social programs. Today, after having a very enriching session with one of India's topmost experts in glaucoma, we now have a session with our own KSOS members discussing various exciting trends in glaucoma. Welcome to the third episode of KSOS Online Journal Club. We today discuss an article on the most common surgery for glaucoma management, trabeculectomy. And this is published in the highest impact online journal, the Scientific Reports from Nature Publishers. And we all know that TRAB is highly effective in controlling eyes control, but also in protecting the nerve, neuro regeneration and neuroprotection. So does good IOP control play a role? What are the other options available? And so to discuss this article, we have an excellent panel of experts here. Dr. Rekha PS, Assistant Professor of Manjeri Medical College, will be presenting the journal. Dr. Bindu S Ajith, Head of Department of Glaucoma at Contrast Eye Hospital, Calicut, will discuss the statistics. The clinical relevance and other aspects will be dealt with by Dr. Girija K, Senior Consultant, Glaucoma at LF Hospital, Angamali, and Dr. Kiran Gopalakrishnan, Senior Consultant, Glaucoma and Anterior Segment at Precise Specialty Eye Care, Trivandrum. And before we start the journal club, let me invite Dr. Arup Chakravarti, President KSOS, for his remarks.
Very good evening, friends. A warm welcome from the President of KSOS on behalf of KSOS. So, Sudha, thank you for taking up this topic, because I think originally it was supposed to be a retina topic. And then we decided that it is World Glaucoma Week. So with a short span of a few days, she changed the topic, selected a very nice topic and equally brilliant speakers for this. So thank you. Another request to Sudha early on was, please ensure that we have at least 50% of the panelists, faculty members are ladies. Today I see that about 80% of these. I think it is the International Women's Day factor. I don't know, but I think this is a good trend, and please keep it up. With these words, I would like again to thank Dr. Gopal, our Secretary, Dr. Srini, our very vibrant Chairman Scientific Committee, for all the support and all the activities that they have been, doing for KSOS. I wish this meeting all the best.
Thank you, sir. Dr. Gopal, please say a few words.
Thank you very much, ma'am. This is an excellent, episode that you're having here. The first two episodes were also very well received. And right now, we are in the midst of a flurry of activities for the World Glaucoma Week. It started with Dr. Tony sir's interview, as well as the CME by the Kasaragod Ophthalmic Society onto glaucoma. Today, we had two programs, one Dr. Ramanjit Sihota coming here with us with an interview, and then this interview, then this journal club. Tomorrow, we have a PG discussion on a glaucoma case. That will be tomorrow. And 10th of March would be a free camp set up by about 150 hospitals across the length and breadth of Kerala, involving each district ophthalmic club, wherein a free screening program is conducted. And then we will have Sir's interview towards the 12th. So that's a busy glaucoma week schedule for all of us. And I expect that this session is also going to be very, very, scientifically motivated. Thank you. Over to you.
Thank you. Dr. Srini, please.
Thank you, Dr. Sudha. Thank you for selecting this topic. Thank you for selecting this excellent article for discussion. And thank you also for selecting this wonderful faculty for discussions. I'm sure that we're going to have a very enriching session today, and it'll be useful for everyone.
Thank you. So Dr. Kiran will be coordinating the sessions. And before that, let me just invite Dr. Rekha to start the session. Rekha, please present.
Okay. Let me share my screen. Is the slide visible, madam?
Yes, yes.
Okay. Okay, so good evening, everybody. I thank KSOS and Sudha madam for giving me this wonderful opportunity. So today we'll be discussing the journal.
Make
1
it
year
full screen,
structural.
Rekha.
I've made it, madam.
Thank you. See if the slides are moving.
No,
Right?
No, sir.
Then you'll have. Yeah. You unshare it. Unshare it now.
Okay.
First, you open your presentation.
Yeah.
Keep it open.
Open, sir. It's open only.
Your presentation is open?
Yes.
Is it? Now you just try and share because it's not moving for us.
Okay.
Do you have an option which screen to share? When you
Share
click
screen.
Yeah. Do you have an option which screen to share? Once you click share screen, do you have multiple options there? Screen one.
Yes, sir.
Desktop.
Yes, yes.
So what is your first option?
I have Microsoft Teams downloads. I mean, I've
No,
selected the
screen.
journal.
The screen.
No,
I think
when you're hitting share screen, you will probably have multiple options, right?
Multiple options.
What is the first option?
No. She's talking about the presentations that are open. Just try it once again. Try it once again. Let's see.
Now,
no, can you move the slides now? Are you moving the slides?
yes.
No, it's not moving for us.
Please unshare, Dr. Rekha.
Okay.
Okay. When you hit share screen, you will have multiple options. Probably the first option is desktop or screen one or something like that.
Yeah.
What is the first
Screen
option?
one.
Yeah, you click that, please. Once you hit share screen, click screen one.
Okay. That's already selected actually.
So you are already selected screen one?
Yes.
Okay, now we are not seeing any. What are the other options then?
Then this PowerPoint, then Microsoft Teams downloads.
Any option for desktop?
Desktop is already.
Okay, now we are getting screen sharing.
Yeah,
right now,
that's
yeah. Now it's full screen.
Yeah.
Full screen. Okay.
Just try moving the slides a bit.
But now actually it is not moving for me.
Okay. So what screen did you select now?
The desktop.
Have you opened the presentation?
Yes.
Rekha, it would be
Yes,
better
sir.
to mail it to Kiran. Mail the presentation to Kiran. It would be better probably. Can you just open the mail and just send it?
Yeah.
Is it okay?
Yeah, sure.
Kiran,
No
can
problem.
you just tell your mail ID?
I'll just send it now.
Yeah, in the chat box you can send it.
It's there.
Okay.
Meanwhile, I think we can have a few words on what is neuroprotection, Dr. Girija. Could you just tell us what is neuroprotection and neuroregeneration, since we are going on into this topic?
Glaucoma, the retinal ganglion cells, the death of retinal ganglion cell is accelerated in glaucoma due to various factors, like an increased IOP being the most important thing, which causes, which increases the glutamate excitotoxicity, the oxidative stress, and many other factors which will increase the RGC apoptosis. So in glaucoma, when we are bringing down the IOP by various measures like medicines or a sudden lowering of IOP, as in trabeculectomy, the retinal ganglion cells definitely show an increased functioning as well as an increased structural and functional improvement. So that is what this journal is about. And when we go through the literature, actually many studies have been conducted regarding the improvement of the RGC functioning. So the neuroprotection in glaucoma treatment is mainly by the main factor, that is the decreased IOP. But there are other agents which have been proposed to have certain neuroprotective effects, like the topical medical agents like brimonidine. It is supposed to have a neuroprotective action, though it is still a doubtful thing. Then there are other.
What they're trying to say is that now we are actually talking about the ganglion cell, more and more important factor rather than just the intraocular pressure. And that is what we are trying to highlight in this journal. That even, and it actually seems that this, before real death occurs, this ganglion cell actually goes to sleep or hibernates. And there is a window period where you can actually activate it, reactivate it, and bring it back to its, maybe not normal, but at least bring it back to some functional purpose. Yes, Dr. Kiran, isn't that what you're talking about?
Yeah, I mean, the article basically looks at improvement of both visual fields on Humphrey perimetry and the RNFL thickness on spectralis. What needs to be emphasized is that the improvement was shown only for 3 months, in the first 3 months with respect to the visual fields, and only for 1 month with respect to the RNFL thickness. And after that, while the study period was 1 year, and during that period, it was basically showing further decline, not further improvement. And but even when it was showing decline, you have to understand that at the end of 1 year, it was still better than what it was at the, before the surgery intervention was initiated. But the actual improvement was noted only in the first 3 months. And we will discuss other studies. Other landmark trials have actually looked at improvement of visual fields. We'll be discussing that as well. All right. So, Dr. Rekha,
are you able to now get the slides?
I haven't received it yet. I'm just refreshing again. Now we are seeing your screen.
Rekha, maybe from the right lower corner, can you make it full screen? From the right lower corner.
Dr. Kiran, I have sent you the mail. Can you have a look?
Yeah, I'm constantly refreshing it. I haven't received it yet. Okay. Yeah, now the slides are moving. What you
let her present like this.
Yeah, you can present.
Let her present like this.
You can
one slide. Let's
yeah,
let's
as long as it is moving, it's
Yeah.
okay. You present.
Yeah.
Rekha.
Okay, sorry for that. So today we'll be discussing the journal 1 year structural and functional glaucoma progression after trabeculectomy. Okay, so it was published in Scientific Reports in the year 2020. So clinically, we all know that reduction of intraocular pressure remains the only proven treatment for glaucoma. And many trials have confirmed the value of lowering intraocular pressure in delaying the visual field progression. So among these important study was the Advanced Glaucoma Intervention Study. It investigated the association between control of intraocular pressure after surgical intervention for glaucoma and visual field deterioration. It had more than 6 years of follow-up, and 738 eyes were studied, and they were divided into 3 groups based on the intraocular pressure. And they found that low intraocular pressure is associated with reduced progression of visual field defect. Next was studies regarding many studies have shown that surgical lowering of intraocular pressure in glaucoma can result in improvement of visual field. Among these was a short-term enhancement of visual field sensitivity in glaucomatous eyes following surgical intraocular pressure reduction. So they examined the hypothesis that surgical intraocular pressure reduction leads to enhancement of visual field sensitivity in glaucomatous eyes. They studied 30 eyes of 30 surgically treated glaucoma patients and 41 eyes of 28 stable controls. The number of eyes with improved pattern standard deviation at follow-up of 3 months was significantly greater in surgically treated eyes compared with the controls. Now, structural changes after trabeculectomy were studied, and among them was a study that is the optic disc and visual field changes after trabeculectomy by Morphulo study group. So here, the changes of optic nerve head structure and visual field sensitivity in glaucoma in patients with glaucoma after trabeculectomy were studied. 250 eyes of 250 patients were studied, and they found that 1/3 of eyes continued to show progression of glaucoma at 5 years after trabeculectomy by analysis of optic nerve head structural changes and visual field sensitivity over time. Okay, so drawback of these studies were here the structural improvement was not seen along with the improved visual fields, and in all these studies, time domain OCTs were used. So they required a manually drawn contour line which can induce operator-induced variability. So the aim of this journal was to assess the impact of trabeculectomy and associated IOP lowering on rates of visual field and RNFL thickness progression, and also to determine the factors related to these changes following trabeculectomy. The inclusion criteria were clinical diagnosis of primary or secondary glaucoma. And trabeculectomy was indicated because of progressing glaucoma or high risk of glaucoma progression due to high intraocular pressure. And they included patients with best corrected Snellen's visual acuity of more than 0.1 and refractive errors were -6 to +6 sphere and ±3 diopters of cylinder. Exclusion criteria were prior intraocular surgery, except phacoemulsification with IOL implantation, other ophthalmological or neurological diseases affecting the visual field, and poor image quality because of opaque ocular media. Now, the definitions used were glaucoma was defined as the presence of glaucomatous optic neuropathy, that is NRR thinning, notching, or RNFL defects, with or without associated glaucomatous field defects. And visual field defect was defined as a glaucoma hemifield test outside normal limits and a cluster of 3 contiguous points on the pattern deviation plot with P less than 5% and 1 with P less than 1%, or a pattern standard deviation of less than 5%. Now coming to the method, it was a longitudinal study of consecutive patients who were undergoing trabeculectomy at the Vilnius University Hospital Santaros from 2014 to 2017. 105 eyes of 100 patients were included in the analysis. So they had 7 follow-up visits. Visit 1 was before the trabeculectomy, Second visit was 3 to 10 days post-operative. And then 1 month post-op, 3, 6, 9, and 12 months post-operative. These were the 7 visits. Majority were examined at 7 visits, and the visual field tests were performed for 5 visits. That is visit 1, that is pre-operative, and then 4 to 7, that is 3 months to 12 months. OCT and intraocular pressure were performed at all 7 visits. Now, the examination procedure was, first a baseline examination was done. That is best corrected visual acuity, autorefractometry, slit lamp biomicroscopy, and a dilated fundus examination. Then the intraocular pressure was measured, that is mean of 2 intraocular pressure measurements using a Goldman's applanation tonometer, and 1 minute apart was taken. Now the visual field, it was a HFA 30-2 CETA strategy done at 5 visits, that is pre-op, post-op 3, 6, 9, and 12 months. The baseline visual field was done twice, and the second one was taken into consideration. And glaucoma severity staging was based on the Hada-Parrish-Anderson criteria. Now, regarding the trabeculectomy, it was a limbal-based trabeculectomy with or without 5-fluorouracil, and the same surgical protocol was followed by one of the 4 surgeons. And if there was a failure of filtering blood, needling with 5-fluorouracil was done. Now, RNFL thickness was analyzed using a spectral domain OCT, and it was done at all the 7 visits. A 15 to 10 degree rectangular scan centered on the optic nerve head was taken, and each OCT will have 49 horizontal B scans at 63 microns interval. 2 OCT scans were taken, and the one with a better quality was taken into consideration. RNFL thickness was measured automatically from a circumferential SD OCT scan of 3.4 millimeter diameter centered at the optic disc. Then lamina cribrosa was studied using OCT. OCT images were enhanced and measurements were extracted using a software. And the criteria used were the curvature of the lamina cribrosa, global shape index, and the mean lamina cribrosa depth, the mean depth of all points on the surface of the lamina cribrosa. These were the criteria used. So this was about the study methods. Now we'll move on to the results. First, the demographic data. The mean age was 67 years, males were more than females. And the important points were the baseline intraocular pressure. The baseline intraocular pressure was 27 millimeter of mercury. And the visual field mean deviation was minus 14 decibels. And global RNFL thickness was 53 microns. Now, these were the lamina cribrosa features. Then glaucoma subtype, pseudo-exfoliative type was the most common. And regarding the glaucoma severity, majority of the patients had severe glaucoma. Now, we'll deal with the changes in the intraocular pressure. You can see that the mean intraocular pressure was 27 millimeter of mercury. And after surgery, in the first post-op visit, that is 3 to 10 days after the surgery, there was a decrease. The intraocular pressure was 9 millimeter of mercury. So there was a mean decrease of 66%, and it was statistically significant. Next was the changes in the visual field. The visual field mean deviation improved during the first 3 months of follow-up. That is, after 3 months after surgery, the visual field, there was an improvement in the visual field. And then it later worsened at the later follow-up visits. Now, changes in the nerve fiber layer thickness. RNF thickness reduced from the first month of follow-up. You can see here there's a gradual decrease in the thickness from the first month of follow-up itself, and the mean RNFL change rate was minus 4.2 microns. Then now we'll see the factors that are associated with the changes in the visual field mean deviation and the RNFL thickness. So the changes were considered into 2 periods. That is, the first period was the baseline to 3rd month. That is the early period. And then that post-operative 3rd month to 12th month. That is a late period. So we'll see the factors related to changes in the visual field mean deviation, the early phase, that is baseline to 3 months post-operative. You can see here in the table, the important, the significant ones are the changes in the RNFL thickness, changes in the intraocular pressure, and severity of glaucoma. That is RNFL thinning, lesser reduction in post-operative intraocular pressure, and severe glaucoma are independently associated with early visual field mean deviation worsening. Now about the factors related to changes in the visual field mean deviation, the late phase, that is 3 months to 12 months. So here also you can see the significant ones were the changes in the visual field mean deviation, that is in the early phase, RNFL thickness and intraocular pressure and severity of glaucoma. That is early visual field mean deviation worsening, RNFL thinning, lesser reduction in postoperative intraocular pressure, and severe glaucoma. All these were independently associated with late visual field mean deviation worsening. Now the factors related to changes in the RNFL thickness. So till now we were discussing about the visual field mean deviation. Now RNFL thickness in the early phase. The early phase, again visual field mean deviation, change in intraocular pressure and also the lamina cribrosa features. So the important points are, in the early period, more pronounced worsening in the visual field, greater reduction in postoperative intraocular pressure. So that was also a factor, greater reduction in the postoperative intraocular pressure. In pseudo-exfoliation glaucoma than angle closure glaucoma, moderate or severe glaucoma than mild, and spherical cup-shaped lamina cribrosa. All these were independently associated with early RNFL thinning. Now in the late phase, you can see worsening in the visual field, increasing postoperative intraocular pressure, pseudo-exfoliative glaucoma, moderate to severe glaucoma, and decreasing lamina cribrosa depth. So all these were independently associated with late RNFL thinning. So to conclude, after trabeculectomy and associated decrease in intraocular pressure, in the visual field, there was an improvement in the visual field mean deviation during the first 3 months of follow-up, that is the early period, and then worsening at later follow-up visits. And RNFL thickness reduced from the first month of follow-up onwards. And RNFL thinning, increasing intraocular pressure, and severe glaucoma were associated with visual field deterioration. And eyes with visual field deterioration, increasing intraocular pressure, and moderate or severe glaucoma were associated with RNFL thinning. And early visual field improvement were more likely to occur in patients with mild to moderate glaucoma. And even in late stage of glaucoma, structural progression can be monitored with RNFL thickness measurement using spectral domain OCT. Now, there are some limitations in the study, that is short observation period, small number of patients, and lack of cataract staging after trabeculectomy. So that's all for today. Thank you.
Thank you. So that was the journal. And now Dr. Bindu will be discussing the statistical analysis of this journal and how relevant it is. We will be talking about that. Dr. Kiran will take over the session from now on.
Is the slides visible?
Yes, madam.
Thank you. Good evening, everyone. I thank Dr. Sudha for giving me this opportunity. And I thank Dr. Praveen Nirmalan for his immense help and guidance. Now, some of the slides are repetition, but we'll just see what the analysis of the title first. So the key elements in the title are the condition of interest is the post-surgery, and the variables what we are studying is structural and the functional changes. And the relationship between the variable is the progression that we are looking for. And the time period is 1 year. And the title does not show how the method of assessment is. Now the rationale was already talked about. Now during the introduction, the authors have already described the limitations, and they have described some of the studies relating to this subject, and they were of the opinion that there were a lot of operator-induced variability in the previous slide. So they opted for the new spectral domain OCT, so they could overcome the operator-induced variability in the data. Now the aim, it was the assess the impact of trabeculectomy and the IOP lowering on the RNFL thickness and the visual field, and also to determine what are the other factors related to these changes following the trap. So the PICO format of the research question, it is the consecutive patients who underwent trabeculectomy study. The intervention was trabeculectomy. The comparison was between the pre and post surgery, and the outcome which was looked for was changes in the visual field and in the RNFL. Now, the study design, though it was not mentioned in the title, in the method, they just mentioned it is a longitudinal study, and it was studied for a period of 1 year. So we presume it is a prospective study. Since a trabeculectomy was done and it was compared the pre and post trabeculectomy, it was an interventional study. Could they do it in any other different way? Could they have done an RCT or a cohort study? But here, since the severe cases, if you are the severe case, if you're grouping into two and doing trab in one and the other modalities in the other, it wouldn't be ethical because the severe case may progress, and hence the longitudinal study would be the best study. Now, coming to the inclusion and exclusion criteria, actually it was already talked upon, but I'll just tell some of the points where the primary or the secondary glaucoma was included that lacks clarity. And again, in the secondary glaucoma, they included only the pseudo-exfoliation glaucoma. And we all know that pseudo-exfoliation glaucoma reacts to medicine and surgery totally different way compared to other glaucoma. So the data with the pseudo-exfoliation glaucoma, can it be generalized to all glaucoma is a question. Now, the visual acuity and refractive error, they selected cases, the extremes of refractive error was excluded so that they could get the variations in the refractive error also can cause variations in the data of the lamina cribrosa measurements and the RNFL measurements. So they excluded that. But that was also taken as a criteria. The visual acuity and refractive error was taken as a criteria to screen cataract actually in the study. They did not mention how they screen the cataract, the grading of the cataract, and even the quality of the scan. There is no clarity on what was the, by which, the way which they, the quality of scan was determined. And in one of the limitations, they say that the reliability of the visual field criteria, they extended a little bit. They've told that they wanted to include more number of severe cases. So in severe cases, we do see more of loss of reliability indices. So that is one of the thing. And actually in the inclusion and exclusion criteria, the failed trab and post complications were not there. But once they selected the case and then they excluded, the failed trab and post-op complications were included in the exclusion. And failed trab, again, the proper definition of failed trab is not mentioned, whether it is on medication or it is just after trab. But there was a mention of 5FU injection and needling being done. So all this lacks clarity because all this can influence the intraocular pressures. And even the post-op complication, whether it was in the initial period or in the late period. Initial period, even hypotony can cause changes in all the parameters too. Now we'll come to the variables which they studied. The primary variables were the intraocular pressure, the mean deviation visual field, the retinal nerve fiber layer thickness, and the lamina cribrosa measurements. Now we come into the details of the variables. These variables are measurable, and there is a continuous change in these variables, and they are dependent on the intervention that we are doing. And it is also measurable and quantitative measurable. So these continuous, dependent, and quantitative variables are tested by correlation, mean, and proportions. Now, there are secondary variables in this are the severity of the glaucoma and the glaucoma subtypes. These are qualitative variables, categorical and ordinal, that is mild, moderate, severe, and they're independent. The intervention does not cause a mild glaucoma to a severe glaucoma. They are independent of the intervention, and the test uses the chi-square test. Now, why did they choose the linear mixed model of regression? As we saw earlier, it had a mix of dependent, independent, continuous, and categorical variables, and there was a hierarchical structure. The mild disease, moderate disease, and severe disease. And the correlation between the eye. We all know the human eye, like chronic diseases like ARMD, diabetes, and glaucoma, affects both eye, but not in symmetrical way, but effect in one eye also affects the slightly related to the other eye. So these all confirm factors are taken into consideration while doing the statistical analysis. And we also are aware that in the longitudinal study, some data is missing in the visits. So that is the unbalanced data and the relatively small number of parameters. And we are studying the individual and the group effect, the fixed and the random effect. So the linear mixed models have a great flexibility in analyzing the longitudinal data. So this was actually already showed. Here they have taken 130 patients, 130 eyes of 124, and then they excluded the parameters which already described. The only thing is they have taken 6 bilateral eye, and we are studying the correlation between eye. Usually when you take bilateral eye, how does it affect the analysis? This is another question. And they've also excluded 13 eyes who could not complete the test. Sorry. We just moved on, I think. I'll just a minute. So the basic patient demographic and clinical characteristic is already talked about. They have included more of pseudo exfoliation, it is 74%. So the results are skewed towards the pseudo exfoliation group. And here you see a 72 or 69% of them are severe disease. So this gives the effect on severe disease. So this is the box plot or whisker plot, which was already described, but I'll just explain. Whisker plot gives you the spread of data from the center. This is the median line, and you have the 75th percentile in the upper line, and the lower one represents the 25th percentile. And if this line is skewed towards the upper or lower, the data is not uniformly distributed. That is what we gain from here. Now, when we see the visual field deviation and the retinal nerve fiber layer thickness, we see the change in the positive in the initial 3 months, but after 3 months to 12 years, it is in the negative. So that is what she was talking about. But another thing, what they found in this is, they're talking about the floor effect. There are studies which shows that in severe disease, it's very difficult to assess the retinal nerve fiber layer thickness. But here they found that even in severe disease, they could assess the progression or retinal nerve fiber layer thinning. So even in a severe disease, this can be used as a parameter to assess the disease progression. Now, this was again the factors related to changes in the visual field mean deviation. This is from baseline to 3rd month, the initial period. Actually, these was already covered, but what I'll tell you is it is done both a univariate and multivariate analysis. So it not only depends upon one factor, but there are other compound factors like RNFL does not only depend upon the visual field, it is also depending upon the age also it can vary, upon the gender it can vary. It also depends upon the central corneal thickness. So all these factors are included and a multivariate regression is calculated. So that is how. So we see that the visual field and mean deviation is seen with the retinal nerve fiber thinning and severe glaucoma and with the less control of intraocular pressure. My slides are not moving. Actually, I have some difficulty now.
Yeah, this can happen in Zoom actually. If you just escape from the slide share, just stop the screen share and yeah, you can again restart sharing and see if it moves. If not, you can avoid the slideshow and just did what Dr. Rekha did.
So I think we stopped it here.
Yeah.
So this is the change that they showed in the late post-op period. What was different from the earlier thing is the early visual field worsening also affected the, if there was an early visual field worsening, it led to more visual field worsening in the late period too. So does that tell you that the initial intraocular pressure control is the most important thing in managing glaucoma so that we can prevent the late worsening? Or does it give you a hint that early surgery and in mild to moderate cases can get a better IOP control and prevent the progression? That is the question we have to find solution to. Again, this was the change in retinal nerve fiber thickness that was analyzed both univariantly and multivariantly. And it was seen that the significant change in intraocular pressure, the severity of the disease, and early visual field worsening affected it. And the Lambda-Cribrosa parameters changes were not much significant. You can see that in the univariant analysis, it shows a significant p-value, but in the multivariant, there is no much clinical statistical significance seen. Again.
Yeah, you can basically do the same again. This sometimes does happen. It's happened to me multiple times. You can basically go down and if I think you are just about to finish the slides.
Yeah.
Yeah, you can just show it otherwise without the slideshow.
So I'll just show you the scatter plot. Here, what they've seen is the change from the baseline to 3 months is in the x-axis, and the change from the baseline to 1 year is the y-axis. And this is the graded according to the severity of glaucoma. We can see that the improvement seen in the x-axis, 0 to 5 years, in the mild and the moderate, still remains in the 0 to 5 in the 1 year also. So the improvement in vision is sustained in the late period also. Whereas in the negative things, the more of severe disease is seen in the 0 to -5. So they compared the pre and post-operative were used for calculation of visual field worsening, and it was found to be significant. The R to 0.32 with a P of 0.005 was found to be clinically significant, statistically significant too. Now, was this visual improvement a sampling error or a regression to mean? What is regression to mean is a repeated measure. The data moves closer to the mean. For that, to avoid that, what they did was they took 2 preoperative baseline fields, and the second one, which they thought that the patient's learning curve is improved in the second one, and that was used for the test analysis. And in addition to that, they did a separate analysis with the first one, and also they did not say the improvement was not seen in the worst baseline visual field mean deviation. And they could also have found a significant correlation between the visual field improvement and the IOP control, and they had the objective and reproducible OCT biomarkers, which shows the same changes in the RNFL thickness also. So what did we learn from this? The visual improvement is short term, which is more in the mild to moderate, which is authenticated by the structural parameters. And if improvement in 3 months, the decline in the later period was also slower. But this study included more of severe disease. So we need studies with more mild and moderate disease so that we could get more insight into it. And whether we need an earlier surgery than medicine in mild to moderate is another question. And they also show that the visual field deteriorates more in severe disease, and this can be measured even in late stages with RNFL parameters. So do we defer surgery in the severe disease, or what can we do to decrease this visual field deterioration in the severe disease. I think the discussion part, they'll be taking care of that, where you can bring down the deterioration by decreasing the sudden hypotony, or the trauma to the optic nerve by peribulbar, going in for a topical, or putting additional releasable sutures and preventing the initial hypotony. And the laminar cribrosa parameters to assess progression is questionable because it is confounded by the severity. So thank you.
Thank you, Dr. Bindu. That was a very comprehensive and excellent statistical analysis of the article. Almost every point has been covered in so much of detail, and your language is more of a statistician language than ophthalmologist. That is absolutely wonderful to hear. So,
except for when the slides got stuck, I got stuck in the middle.
Yeah. All right. So let me initiate the discussion by just summarizing certain points of the study, and then we will take it point by point. So one of the important things to be noted here is that we were dealing...
Dr. Bindu, could you stop sharing this? Thank you.
Okay. Okay. So one of the, I'm just highlighting certain important points in this study. This is important to understand because the general impression with improvement in visual fields or improvement in structure following intraocular pressure control has been traditionally described for congenital glaucomas and juvenile glaucomas. This was the traditional description, but if you actually notice the literature, even since 1985, there has been publications regarding the possibility of improvement in visual fields, and we will look at how these improvement in visual fields come about and what are the common features in studies which show visual field improvement and what are the factors that do not come in common. So one of the notable points in the study is that we were dealing with a very high predominance of severe glaucomas. The mean deviation, if you take the mean deviation of the total visual fields, it was nearly 14 decibels, around close to 15 decibels. The other thing is we had a baseline intraocular pressure pre-op of from 27, and the pressure was brought down to almost 9 on an average, and then kind of settled down around 12. So again, we are looking at 66% reduction in intraocular pressure, and this is generally attained only with surgery and not with drugs. So the first thing obviously that comes to our mind is, and this I think Dr. Bindu has already touched upon, but I think it's very important to discuss this. So I am just asking Dr. Bindu to come to this particular point again. So is the temporary improvement in visual fields actually a real improvement? Or do you think that any statistical error might have actually contributed to this? You have already mentioned that the possibility of regression to the mean and how this is less likely to be a regression to the mean. So are these visual field improvements real? Dr. Bindu, your...
Yeah. So according to this study, where they have taken consideration of errors and bias, and then again redone the statistical analysis, it is seen that there is an improvement in the initial period. That is what all the graphs and the explanation, statistical analysis explanation says, that there is an improvement, but it is in the initial period only.
Yeah, but can't it be a simple regression to the mean? That is the important question.
So that is why they explain it is not a regression to mean, because they have done multiple calculation with a multiple field, both the 2 times with the initial field, if it is a learning curve, they have done with both the fields.
Right. So the first thing that comes to mind whenever we see a visual field improvement is the possibility that this is a random fluctuation, isn't that? And what they have argued is it is not likely to be random fluctuation because one, they have taken at least 2 visual fields prior to trabeculectomy, and they have taken the worst visual field for analysis. That is number one point that they're saying. And another point they're saying is that
they have a structural correlation to that.
Yeah, also. Structural correlation. There is correlation with structure. And also you could also argue that there are other corroborative studies that also mentions the same thing. And an important point that again goes against regression to the mean or a random fluctuation is the fact that the people who actually showed improvement were actually the ones with mild to moderate defect. Yeah, if it was a random fluctuation, you would have actually found improvement more with those people who had worse visual field defects in the initial phase. All right, so this is a result that we have to take very seriously, because obviously it is very less likely that this is a regression to the mean. But the other thing is, can you just summarize what are the limitations this study had, gross limitations? I mean, not cherry picking, but major limitations that could have influenced results. For example, you did
the pseudo exfoliation part. The most 70% of the case was pseudo exfoliation. That is, they're comparing it with that. So in severe disease, and the results of surgery and the medication, it is difficult to control IOP and difficult to treat. And the progression is also more in pseudo exfoliation. So the severe disease progression can be taken as comparable to all other open angle glaucoma too. Is that?
Right, that is one point. Anything else that comes to your mind when you look at a main limitation?
The other thing was, it is the mild and the moderate were very less in number. The study done more in the severe cases.
Yes, that's also not entirely unexpected, because this was a surgical study. So you are more likely to operate on trabeculectomies where the patients have severe glaucoma. That's more likely. And some other things in the methodology that should be, I think, mentioned is, one, the visual fields were performed using 30-2. All right. And this in advanced glaucomas can be actually more erroneous. In advanced glaucomas, we actually do 10-2 more than 30-2. They had to do, they did do 30-2 here. So that is likely to create more errors, one. And the fact that because a lot of these patients had severe glaucoma, which means 30-2 is likely to be in error. That is one point. The other thing is lack of cataract staging. That is very important, because the decline of visual fields after the 3-month period up to 1 year could be because of some
development. But then they have touched upon that point. They told there is a structural correlation. That is why it is not due to cataract, but due to the...
Yeah, there is a structural correlation.
They touched that point too.
Yeah, and one of the arguments is that the quality of the scan has been looked at. Right, the quality of the scan, they have actually said that quality scan, they have done spectralis and the quality score less than 15 were excluded. But again, if you use spectralis,
to pull out cataract by that way.
Yeah, but if you use spectralis enough, you also realize that even
with cataract also you get better.
You can get in with spectralis, you can get
good
quality scan with 25 or more even with cataracts. And the other thing is the visual field criteria as far as the false positive negative errors, they put it as 33%.
33. They wanted to include more cases of severe, and in severe these errors are acceptable. That is what their explanation is.
Yeah. So these are things that can actually influence the results, because all of us know that visual fields, can be a very tricky thing to take over a period of time. Dr. Girija, do you think that intraocular pressure lowering is still the best form of neuroprotection? Because you touched upon neuroprotection, do you think there are other possibilities of what are the current drugs? You mentioned brimonidine. Any other drugs do you think that might be neuroprotective, or other mechanisms that you feel might be helpful in neuroprotection?
In the current scenario, actually, the decrease in IOP is the best solution for treatment of glaucoma.
Right.
Yeah, that is depending on the severity of the case, we either use medications or we do surgery. So depending on the selection criteria. But all these other medications, the medication that has been mentioned, one is brimonidine.
Yes.
That is supported by the LOAD study, which has a lot of drawbacks. LOAD study actually compared the outcome of a group of patients treated with brimonidine and timolol. But then it is an old study for one thing, and there were several dropouts, and it was a small number of patients. And this brimonidine patients had slow progression of visual field. That is what they claimed. But this actually, the brimonidine, after that, no serious study has been conducted, and so hence we are not sure of the neuroprotective action, even though many mechanisms have been postulated.
Yes.
Then the ROCK inhibitors are said to have some role, like the Rho kinases are involved in the cellular division, apoptosis, etc. So the ROCK inhibitors are also said to have, but studies are still going on only. Then all other neuroprotective agents like ginkgo biloba, then citicoline, all these agents have been tried, but they are still under this thing, NMDA. Then yes, the citicoline eye drops have been tried, but oral citicoline has a comparable effect. So that has been tried, and that has been actually recommended by the European Union as a food supplementation. So many neuroprotective agents, but since today, nothing has been proven, actually, definitely proven. It requires large number of studies with large number of patients to have a definitive answer.
Yeah. Anybody else wants to comment? Dr. Rekha, you want to comment on neuroprotection?
The ROCK kinase inhibitors, they say they also claim to have a neuroprotective action.
Yeah. Yeah. The thing is with neuroprotection, I suggest that the audience can read a review article published in the Indian Journal of Ophthalmology just last month. In the February edition, there is a review article on neuroprotection. It is basically written by our colleagues from Aravind Pondicherry. So they see, for any drug to be neuroprotective, there are some criteria. For example, there has to be the corresponding receptors that is either present in the retina or the optic nerve. There has to be a plausible mechanism of action, and 3, that those drugs have to be present in enough concentrations in these neighboring regions of the retina or the optic nerve. And finally, they have to be proven with the help of prospective randomized controlled trials. And the only positive trial which is prospective and randomized and controlled was the LOX trial, which Dr. Girija mentioned. But as I said, the biggest problem with the LOX trial was that the brimonidine arm had a nearly 20% dropout rate because of allergies, which are quite common with brimonidine. And these people were not included in the statistical analysis. And the possibility was that suppose these patients, 20% patients who dropped out, had actually progression of visual fields that was not included in the statistical analysis, then the neuroprotective effect would not come true. But there has been other small studies with brimonidine, I have to say, that actually, for example, a study that showed improved contrast sensitivity compared to the timolol arm, though the intraocular pressure lowering effects were almost similar between the two, but that has not been replicated in other studies. So the LOX trial has not been replicated in other studies. So the question of brimonidine is doubtful. The problem with ROCK kinase inhibitors again is that they seem to work very well in animal models, in crush injury models and those models. But then there are a lot of drugs that work well with such models. The biggest optimism was regarding memantine. Because memantine is a drug that is used for Alzheimer's, and it is shown in Alzheimer's to reverse early dementia. So there was a huge enthusiasm regarding the use of memantine, and memantine underwent a very large trial RCT in the US. It was a very hugely funded study, I think running into $1 million or more. I don't exactly remember. It was a very funded study, but the results was actually unequivocal. It was equivocal. It was not particularly effective. So currently, I think there is no neuroprotective agent that can actually prevent RGC degeneration so far. And intraocular pressure lowering seems to be the best neuroprotection at this point of time. And does anybody want to comment on maybe other studies that have actually looked at visual field improvement after performing a trabeculectomy or after intraocular pressure lowering? Dr. Rekha did mention a couple of them, right? The MoreFlow 5FU study. Can you just say a few words regarding other? This study does show some improvement for 3 months. So what about other studies that have been done in the past that has shown similar results or opposing results? Dr. Rekha, you are muted. Can you please unmute yourself?
Hello.
Yeah. Please go ahead.
Yeah. There are many studies showing minimal improvement, but most of them are not very statistically significant. like the studies I don't exactly remember.
Yeah, it's all right. It's all right. So I think we have a question from the chat box from Dr. Praveen Nirmalan. So he has been listening to this. Okay. So his question is, how do you assess the efficacy of neuroprotection objectively? I mean, I haven't understood that question completely, but my understanding is that in generally, if you are claiming that one drug is neuroprotective, you essentially have to compare it with, say, another drugs. For example, the Locke study basically compared two drugs, brimonidine and timolol. If you consider these two arms, the intraocular pressure lowering was similar between these two, right? But if you looked at the visual field deterioration, the visual fields were preserved better in the brimonidine arm. So if the intraocular pressure, which is a very well-known risk factor, was similar between the two arms, what helped the brimonidine patients to have better preserved visual fields? So the argument is that is most likely an IOP independent factor. It can only argue that it is an IOP independent factor. So while neuroprotection in general refers to any deterioration, any prevention of deterioration of RGC loss, and that includes IOP lowering also, for the purposes of discussion of neuroprotection in glaucoma, we are considering IOP lowering drugs as a separate entity. So if between the two, okay, his next question is, does imaging of the lateral geniculate nuclei help? I have no idea, sir, whether imaging of the lateral geniculate nuclei will help on this or not. But certainly in conditions like Alzheimer's, they have been able to actually show neuroprotection and some degree of neuro regeneration with memantine. But I have no idea whether imaging of the lateral geniculate nuclei helps or not. He is actually posting this question on the chat box. Anybody else?
Brimonidine actually, I would like to add, brimonidine actually, it's an alpha agonist, alpha-2 agonist, and these alpha-2 receptors have been identified in the retinal ganglion cells.
Yes, yes. Yeah, madam, you're rightly said.
So that is one of the mechanisms that's suggested.
Yeah, currently there are 4 criteria that has to be satisfied if a drug has to be considered neuroprotective. So there are 4 criteria that has to be satisfied. I just mentioned that one is you have to have corresponding receptors that is present in the retina and the optic nerve. 2, there has to be a plausible mechanism of action whereby your drug is going to act on these receptors. And 3, these drugs have to be present in adequate concentrations in the region of these receptors. And 4, they have to be shown in prospective randomized control trials. So, and if you take all the 4 criteria, a lot of drugs do satisfy the first 3 criteria. A lot of drugs satisfies the first 3 criteria, including the newer ROCK inhibitors. But in prospective randomized control trials, that has not been shown to be effective. Okay, so I just wanted to mention, Dr. Bindu, do you have any comments on other studies that might have shown similar or opposing results and why that could be different or same?
No, actually, I want to talk more about why the visual field is deteriorating more in the severe disease even after surgery, because this was a short period improvement only.
Yes.
So we can't take it as granted that it is going to improve. And it was done on a very small sample of mild and moderate.
Yes. But what I am trying to say is, I am not even suggesting that your.
But the final conclusion is it is deteriorating.
Yes, final conclusion. Yes, final conclusion is that it is deteriorating. Yes, but one thing about the visual fields is that even at the end of 1 year, even if you consider the deterioration part, it was still better than
slightly with better the patients who improved in the initial period. Yeah.
If you take the mean of I think the mean MD. You will find that the average was about -14 prior to surgery. And at the end of, even after the end of deterioration, it was still around -13, -13.5. But it is a fact that in advanced glaucomas, in almost all landmark trials, you have seen that over a period of time, visual fields do deteriorate. All you can do by aggressive treatment is actually prevent the rate of deterioration. But if you follow patients up for enough period of time, if all glaucoma patients are going to live till 150 years, with current treatments, everybody should actually go blind, right? Because over a period of time, visual fields do deteriorate. But this test also shows that the greater the magnitude of intraocular pressure reduction, you are less likely to have further deterioration. The other studies, I want to specifically mention the other studies because a lot of the statistical problems with the current study has been addressed in actual studies which were done in the past. We know about the landmark trials. For example, the EMGT, the early manifest glaucoma treatment trial, which was actually the first study that clearly objectively showed us that intraocular pressure lowering delays progression of disease. So in the EMGT study, again, this was looked at, though it was published only in 2016 and the EMGT was done a couple of decades back. It was published in 2016, the EMGT results of visual field improvements. And they found that, yes, visual fields do improve after intraocular pressure reduction in some percentage of patients, but it was the same as the control arm. So they are actually saying it is actually, it's just a random fluctuation. So in the EMGT, you mentioned about the fact that this study looked at mainly severe disease. EMGT by definition included only patients with mild to moderate, mild to moderate disease. None of them had intraocular pressures above 30. And because you are treating them with betaxolol, basically,
that also is claimed to neuroprotective.
Yeah, but the point is the intraocular pressure reduction that was found in EMGT was nowhere comparable in terms of the intraocular pressure reduction in this current study, which is like 50 to 66%, in fact, where EMGT, the average intraocular pressure reduction was much lower. But interestingly, in the EMGT study, some patients did improve and some patients worsened. But even in the control arm, some patients improved. In the control arm was placebo. That means they were not being treated. Even though the patients who were not being treated showed some improvement. All the same percentage of patients, in fact, improved compared in the control arm and in the treatment arm. So the EMGT study is very unequivocal regarding this, and it does not suggest that there is an improvement. And the EMGT study, visual fields are taken at a much more rigorous method. They do 3 baseline fields. They are doing a 30-2 full threshold program. And it's a much more rigorous, and such kind of rigorous analysis is practically impossible in patients who are waiting for TRAB and who have undergone TRAB. Yeah. But the EMGT study did not show an improvement. In the SIJIT study, which also I think was alluded to, SIJIT study is the collaborative initial glaucoma treatment study. And this was comparing the surgical arm versus medical arm. So these patients were randomized into medicine or surgery at the first diagnosis itself. In those patients, again, they found that in the group of patients with the maximum intraocular pressure lowering, there was some improvement in visual fields, at least in the short term. So it seems that one of the takeaways is that if you achieve very high intraocular pressure reduction, you can have some visual field improvement, at least even if it's for a short term. But if you don't get adequate intraocular pressure reduction, your visual fields are going to deteriorate at a much faster pace. But certainly this would not be, do you think that this should be a part of our discussion with the patients, that if we operate, your visual fields are going to improve?
It should not be.
It should not be, yes. Okay. Now,
in the SIJIT study, actually, it was in the initial 5 years, there was a comparable visual gain and loss in the groups.
Yeah, in both
comparable
the groups,
percentage of patients.
Comparable
In the first 5 years.
Yeah.
But later, most of them went into deterioration.
Again,
9-year follow-up study shows.
Yes, in the SIJIT study, it's also important to know that while in the overall study showed equal results with the medicines and surgery, it was in severe glaucomas, surgery was better. Because again, with surgery, you were able to obtain much better reduction of intraocular pressure. So
and it was a pristine conjunctiva. So surgical outcome supposed to be better because they were not receiving medicines for a long time.
Yeah, we will not
all
be
our patients are like,
yes, that is
all our patients are having maximum medications for a long time. Then we opt for surgery.
Then we opt for surgery. Yes.
That is a different thing.
Yeah, but I think one of the key takeaways is that with the greatest reduction of intraocular pressure, you might see some visual field improvement, and but that might be only for
a deterioration.
Even if it is for a short period of time. Yeah. The other one
slow down the progression.
Yes.
And actually, after this, I just went through a few of our case sheets, and actually one of my patients claimed that his visual field has improved. And when I checked, actually it is dramatic. It was a young patient with a traumatic secondary glaucoma. Patient was telling me that, madam, definitely it has improved. But I don't know whether it's true or not. It has improved. That's true, but I have to analyze it and then say. So we cannot tell the patients that it's going to improve. That's Actually, that is one of their main questions.
Yeah, but
whether it
I
will
think it simply highlights again the fact that very strong intraocular pressure reduction is probably the best form of neuroprotection currently. And yeah, any other things to be discussed? Any other points that comes to your mind?
So what do we do to the severe disease which is going to progress?
I think if you look at all the data over all the landmark trials in severe disease, your best option is to perform a filtration surgery and reduce the intraocular pressure to the maximum lower possible range. Again, the danger of trying to achieve a very low target pressure with the trabeculectomy is you can err on the other side and create hypotony and whatnot.
Especially in the severe.
Yes, but again, that is still our only option and the best option to achieve maximum intraocular pressure reduction so that the deterioration is as low as possible.
But there are studies which say that if you have a severe disease and a cataract, and if the patient is controlled with with medication, you better go for cataract surgery and preserve the visual field. Deterioration can be preserved better in those cases rather than going for traps.
That would be applicable if the intraocular pressures were within your target pressures. Right.
So that is actually the question that I wanted to know. Why aren't you actually saying that trab is a good option? So why not go in for mild and moderate? What is the risk? There must be a risk. That is the reason why we're not going. Yes.
Okay. I think the complications and the results, complications of trab are just too many to count. It is still a relatively unpredictable surgery in the sense that the more filtration you try to attempt, the greater chances that you end up in hypotony. So you cannot currently achieve very low intraocular pressures by opting for higher titration and be very safe at the same time. That is not possible. The whole purpose of having these minimally invasive glaucoma surgeries is to produce lesser intraocular pressure reduction, but be more safe. If you want to perform trab, you depending on the surgical technique, sometimes you, depending upon the adjuvants you use, for example, you use 0.4 milligram per ml instead of 0.2. Yes, you are more likely to get better control of intraocular pressure. But again, you are not only at risk of developing hypotony in the early phase, but late blood leaks and other complications. So that is the big issue. Even in mild to moderate glaucoma, all the complications of trab still do exist. And they might be not huge in number, but in mild to moderate glaucomas, if you are able to achieve adequate intraocular pressure reduction by medicines alone, you can avoid basically the risks of glaucoma. And the whole purpose of mix again is to actually, in these mild to moderate glaucomas, to avoid the trab risks, you perform mix.
And how long does the effect last, the trab? For instance, if you're doing trab, I mean, is it successful for your lifetime?
The trab results are generally always described in terms of number of years, right? So if you look at multiple published studies, you will find that
experience?
My experience, I haven't done my data, madam. I will not talk about my experience. I'm talking about large published trials, which will tell you that over 5 years time period, the trabeculectomy is generally going to have an absolute success of around 70-75%, and qualified success certainly much more than that. And over 10 years, the efficacy, again, the absolute success rates comes down to 50 to 55%.
No, that's not clear.
What is not clear, madam? Sorry?
So for a person who needs a long-term control,
it
was not clear, the connection went.
Oh, sorry. Yeah.
So for 10 years, you're saying it drops.
Of course.
Finally drops.
Trab is eventually a surgery that has a success rate defined in terms of time frame. So when somebody asks me, what is your success rate in trab? I can say that this is my percentage of success in 5 years. This is my percentage of success in 8 years. This is my percentage of success in 10 years. It is always going to drop. Otherwise, we wouldn't need retraps. We wouldn't need valve surgeries. Obviously, the efficacy.
And how successful is the retrap? It won't be as successful as the first.
Yeah, if you have a failed trap, then the big question is whether you want to do a retrap or you want to do a valve surgery, right? And that is what basically the TVT trial looked at, isn't the tube versus trabeculectomy trial, which looked at patients who had undergone a surgery before. And they found that, the tubes seem to work better in resurgeries than traps. But in primary TVT, that is the primary study. So if you have a patient who needs surgery right now and you want to choose between trab or valve, in the primary TVT study, the safer option was actually tubes. And if you do enough tubes, I think the safer option is going to be tube, because it does not produce that, huge hypotony and such complications to the same
It is in the
extent.
valve tubes.
Yeah.
They did it in the valve.
Yeah, they did it. No, they actually did it in unvalved. They use Barwelt. They use Barwelt for the primary TVT. With the valve tubes that we generally use, I think the AGV is a valve tube. You are less likely to develop hypotony and other complications. With trabs, you are more likely to face this complication, but the effectiveness was better in first surgery for trab and not for tubes.
So let me just sum up our findings in this journal.
Yeah.
We did find that trabeculectomy helped, in especially where the initial worsening was decreased, and those who had that decrease were actually better off in the late version also. So there was a slight slowing off in most people, and maybe if we had not done the surgery, it would have progressed faster. But how persistent it is, we've just only gone up to 1 year. And the problems, as you said, the problems in mild and moderate are much more. So since in severe, we will anyway go in for trabeculectomy. So possibly there is some benefit in trabeculectomy, but it is not enough to claim that there is any neuro regeneration or a neuroprotection in these affairs.
No,
we do not yet have any good neuroprotective agents.
No, I think there is neuroprotection here described. The neuroprotection is IOP lowering, significant IOP lowering of 66%, as I said. I think that is certainly some form of neuroprotection.
Okay, so it maintains your whatever it's mainly a maintainer rather than a regenerator.
Yes,
so it is not regenerated. This article is not really talked about regeneration. It's just telling us that our progression is slower, but that has already been proved before also. So we have not yet reached that stage.
Right, but there have been studies in generally wherever surgeries were involved, there has been studies which show at least for a period of time some improvement. I mean, the first study you have to understand goes way back to 1985 to 89. Dr. George Spade's study, I think Dr. George Spade was one of our Drishti speakers. So I just wanted to mention that he was one of the first people who actually looked at the possibility of reversal. Of course, he was not using OCTs or things at that time. They were using stereo disc photographs and visual fields, and visual fields were being done at that time with Goldman kinetic perimetry. They had also access to octopus static perimetry at that time. This was again published in both 1985 and 89. So in his group of patients also, he basically categorized the patients into two arms. Ones with greater than, this was a retrospective review, ones with greater than 30% reduction and the ones with less than 20%. So that to maximize the difference between the two arms. And again, it was found that it is a higher percentage of patients in the greater than 30% reduction which showed some improvement in, both in neuroretinal trim on stereo disc photographs as well as in visual fields. And these stereo photographs were also masked. So I think this concept of some improvement following aggressive intraocular pressure reduction has been there for quite some time. But eventually the fact of the matter is you can expect some degree of deterioration over a period of time.
Okay, so with that note, I would like to thank everybody for this presentation during our glaucoma week. And I think we have basically discussed most aspects of what, at least we've come to the point that we are now discussing neuro regeneration, where the ganglion cell is being considered the more important rather than the optic nerve. So we are actually trying to preserve the ganglion cell function. So thank you all for this topic today. And thank you for listening, the audience also. I would like to also thank our KSOS representatives, the president, the secretary, and the scientific chairman, and also Ankit for this journal session. Thank you all. And the next journal will be on retina and probably on the second Friday. Thank you. Thank you all.
Thank you.
Thank you. Thank you.
Ankit, you can stop the live.
Live was ended, ma'am.